Thank you, Beth, for that long introduction. I want to make sure everybody's here. I have said next time I want the morning slot. So everybody is awake after the lunch that usually comes. So usually I've been used to give the ACCIAHA talk, but we've changed the gear this year, talk about the heart valves. Just to go over, the heart has 4 valves, so as mentioned here, which is the aortic valve, the mitral valve, tricuspid, and pulmonic. So what has happened is, in the past, it used to be surgical treatment for a majority of these cases, but in the last, I would say, decade, things have changed. There have been percutaneous treatment for these valves. So you have aortic valve percutaneous treatment, for mitral valve. For the mitral valve, there's also for regurgitation what we talk about clip. Same thing with the tricuspid, as a clip for tricuspid, and for the pulmonic, the melody valve. So if you go to aortic stenosis, if you see what is normal, this normal looking valve where you have 3 to 4 centimeters squared is a normal area. When it becomes less than 0.7 centimeters squared, we call it critical, or severe when it is 1 centimeter squared. This is the time if patient is symptomatic, they need treatment. Etiology is severe, but elderly, most often what we see is the calcific aortic stenosis in these patients. And same thing, that if you have aortic stenosis and somebody has developed symptoms, based on what symptoms they have, your life expectancy goes with that. So importance that if you have developed heart failure in the presence of aortic stenosis, this is that your life expectancy would be 1 to 2 years after that. Like I mentioned, the treatment of choice for this aortic stenotic patient has been SAVR, which is called a surgical AVR, aortic valve replacement, which was the standard of care, as shown here. But things have changed lately, was percutaneous treatment for this, and the valves that I've shown here. And in a very small subgroup of patients where none of this treatment can be done, you can still consider BAV just to keep the survival going. So ACCIAHA guideline, the flow chart is very clear that if you have aortic stenosis where you think your valve area is 1 centimeter squared, or most important, when you do echocardiogram, your mean gradient, not peak, mean gradient, if it is more than 40 millimeters of mercury, and you have symptoms. Usual symptoms is dyspnea, decrease in exercise tolerance, plus or minus angina. If you have symptoms, definitely they will need treatment. If there's underlying coronary artery disease, will require coronary artery bypass surgery plus treatment at that time. So here are the couple of times when you think that LV function normal or abnormal, then you do other tests for these patients. Why somebody with aortic stenosis require treatment is because surgery has shown to prolong life, they live better, and more important is that improvement is LV function if they had developed LV dysfunction. Now, how do we make a decision which patient should get surgical treatment and which patient should get transcatheter valvular treatment is based on the risk factors they have, and that's what's called as a surgical risk factor, STS calculator, which anybody can go online and check how this risk is calculated. So based on the risk, if anybody risk is more than 8, we say it is, so if you see here, less than 3 would be low to intermediate risk, but I would say up to 8 would be, this is low risk, this is intermediate risk up to 8, and anything above 8 you would say high risk, and then extreme risk when it's more than 15% of the time. So majority of the time up to this, low to high risk patients were getting surgical treatment. But since the advent of this percutaneous valve, high risk as well as intermediate risk patients have been shown to benefit from what is called as the percutaneous valve treatment, and again if they are symptomatic. So FDA had approved for both of this group. However, for the low risk group, the trials are still ongoing. Now, These patients also, what happens is they are called as, they have to be considered as prohibitive surgical risk in this case. And what is prohibitive surgical risk? On top of your STS risk would be that they have hostile mediastinum, heavy calcium in the aorta so that they are unable to do surgery, presence of cabbage with lima that is behind the sternum, severe COPD, and more important is extreme frailty. That they may not have a lot of risk factors, but the patients are frail, they probably are not appropriate candidates to have SAVR. These patients will have a heart team discussion where both the interventionalists and surgeons will see the patient, and then the surgeons have to deem that these patients are intermediate to high risk, and that is how they will be getting TAVR. The two FDA-approved devices currently that we have is a Medtronic core valve as well as the Transcatheter, which is a SAPIEN, as you see here, which is a balloon expandable valve. This is a self-expanding valve. If anybody has seen our cases done yesterday, we did 2 TAVR cases with the core valve, and the SAPIEN was actually used in the mitral valve-in-valve case. So just to show you a case here, a 94-year-old female who presented way back in 2014, same with the dyspnea and fatigue, was on good medical therapy for past medical history of hypertension and medical treatment only one. Severe aortic stenosis with a gradient, if you see her mean of 44 or so, EKG sinus rhythm. So what she had a right left heart cath. Before that she had echo showed that she had severe aortic stenosis with a gradient of 48 millimeters of mercury. This is what, look at how her coronary arteries are. So if you see, the left main looks okay, heavily calcified LAD, significant disease of the circumflex. So already she had 2 vessel disease. This is a calcific aortic valve. She has calcium along the mitral valve annulus also. Again, LAD as well as diagonal disease. And this is the right coronary artery, significant disease of the right coronary artery. So 94, severe AS as well as 3 vessel disease. This is the hemodynamic showing that she has significant aortic stenosis, a gradient between LV and aorta. So her STS mortality was about 8.1. So patient was determined to be high risk for a surgical AVR plus cabbage. A patient like this who has such bad coronary artery disease will require revascularization of her coronary arteries. And due to the advanced age, when she had the heart team discussion, the question is what could be done. So the decision in this kind of patients, that patient is mentally alert, okay, and no frailty, those 94 should be given a chance. So what we did was that this patient should get coronary artery disease treated with percutaneous treatment and then get a TAVR. So before you do, somebody who has severe aortic stenosis and you're going to intervene on a severe coronary artery disease, that you have to do balloon valvuloplasty, which is a temporary measure so that the valve has opened somewhat when you're doing the procedure. And take care of the LAD, you put 1 stent, and then circumflex was also taken care. Later on came back, had a right coronary artery intervened. 2 stents in the right coronary artery. And after 2 months, she came and she had the Medtronic core valve placed, and patient is still doing fine. So essentially, what is the guideline you have right now? Choice of TAVR versus surgical AVR in patients with severe aortic stenosis, that if you have prohibitive surgical risk, when your STS is more than 15, TAVR should be the indication, class 1 indication. High risk surgical, which we can consider either that they have AVR or TAVR, there's a class 1 indication. But for intermediate risk would be the same. That TAVR is a class 2 indication, that surgical AVR still should be considered. And for low risk patient where we are saying your STS score is less than 3, so at this time the trial is ongoing. Till then, surgical AVR would be the class 1 indication for these patients. So in 2018 and future, what is the future for TAVR? Or what are the other indications that where you can use percutaneous valve in patients with aortic stenosis? Is valve-in-valve, exactly what we showed yesterday. The patient already had a surgical AVR in the past and now has come back with severe aortic stenosis. You can consider a TAVR in those patients. Patients with predominant aortic regurgitation. What I mentioned was aortic stenosis. So when in the etiology, I did say that it is calcific aortic stenosis. So when there is calcium, this prosthetic valve are being held and they are anchored in the calcium. But when you have predominant aortic regurgitation, the current valves which were made for patients with aortic stenosis are not the right kind of valve. So they could be future different kind of valves for this pathology. Bicuspid aortic stenosis, in all the trials they were excluded, but currently that they could be used for clinical indication. Similarly, for patients with small LV and severe LV dysfunction, TAVR could be done, and the same thing would be early TAVR, where you have asymptomatic severe aortic stenosis. Could that be done? Now, this is the valve-in-valve, the case that exactly what we showed yesterday. Yesterday we did a Medtronic core valve. This is a SAPIEN valve. After the TAVR placement. What are the potential complications of TAVR? They are relatively common and some of the most infrequent. So more common would be stroke and death, AV pacemaker, especially depending on type of the valve that they're going to get, and vascular complication. So I would say in the order, that vascular complication probably would be the number one. Second one could be the pacemaker, which is probably just around less than 10% at this time, one of the kind of with the core valve, and the rest would be the stroke, which is probably less than about 2% or so. And of course, the others that you need to think about would be paravalvular regurgitation and acute kidney injury. Yesterday, during the live case, we did show that we had to protect the left main. The rare thing that we can see is what's called as coronary obstruction, that when you're placing the new valve, the native valve will be behind and could obstruct the coronaries. So we need to be worried about that, and we can, like we did yesterday, should be cautious how you take care of that. And the rare things that could happen would be annular rupture, ventricular perforation, and of course at follow-up endocarditis. So how do you take care of CVA? That is, you have an intermediate, or you're even doing it in a low-risk patient. It would be devastating that TAVR went well, but patient had a CVA. There is what is called as a cerebral embolic protection device. What you do is you use these umbrellas in the two carotids. You go while the radial, place this umbrella in both the carotid to protect and prevent the from a patient having CVA. The other emerging devices, the several devices out there for the TAVR, and more important would be for pure AI, like I showed you, is a different kind of a valve, so that there's no calcium. These valves are out there so that they get anchored in the LVOT or on the upper part of the aorta, so that they are stable and do not fly out. This is the growth of TAVR procedure in Mount Sinai. The last year we did about 306 cases, but more important, you look at here, the length of stay definitely has decreased. Essentially, we are actually, for the SAPIEN valve, you are thinking about if there is no need for a temporary wire that should be left, in that they could actually go home within 48 hours with the observed the mortality rate, I would say mortality of less than 1%. Now, these are the complications when you compare Mount Sinai with TVT registry, which is the national registry, which Beth mentioned in the morning, that we are part of all these registries that are here. Look at that, Mount Sinai, the in-hospital mortality rate, lower. 30-day mortality rate, lower. And only thing is slightly higher here is pacemaker because of the kind of valve we use. but it's still not significant difference, but we're still, we are hovering about 10% or so, and 1-year mortality about 10%, which is way better. And majority of the cases are done from femoral root. And in the early part, we used to use what is called as general anesthesia, but if you see here, the patients that are getting conscious sedation, means just anesthetist is in the room, but under conscious sedation, about 80% or so. Like we do our other teaching, we also have the structural heart webcast series, which we do every other month on second Tuesday, just to teach how the structural heart cases are being done. Moving on to the mitral. So just I'm going to talk about mitral regurgitation. Mitral stenosis, just to say what's the treatment. Majority of these patients are because of rheumatic heart disease, and the treatment of choice is percutaneous still, to do a balloon mitral valvuloplasty. But if you have mitral regurgitation, just to tell you what's the prevalence of mitral regurgitation, about 4.1 million patients with mitral regurgitation, and more, if you see here, 3+ mitral regurgitation, about 1.7 million or so, 14% newly diagnosed every year. But annual mitral valve surgery, about 30,000, essentially saying from 4.1, about only 2% are treated. So there's a large unmet need, that a large of patients out there who are not getting the treatment. So two kinds of mitral regurgitation, if you go to classification of these cases, is that one is the primary, where you have problem with the anatomical with the valve itself. There is some problem with the valve, leaflet, subvalvular apparatus. And the second one is what is called as a functional or secondary MR. Nothing wrong with the valve as such, but this LV is dilated, and patient develops some kind of heart failure, dilation of the annulus, and patient gets mitral regurgitation. So that is the secondary mitral regurgitation. Right now, we focus on what is the primary or degenerated mitral stenosis. So if you see here, everybody has to be on medical therapy. When medical therapy fails, the treatment of choice has been to get mitral valve surgery, which is very invasive. So the treatment, percutaneous treatment, which has been there out for the last few years, is what is called as the mitral clip. It is a venous procedure, exactly like we did the mitral valve yesterday, that you do a transeptal, then you place your catheter across the transeptal. Then what you do is take the clip, advance the clip through this, and you are able to move this with the catheter, lateral, medial. You can go anterior, posterior, get into the valve. So this procedure is done with the echocardiographer in the room, like you saw the case we did yesterday. So we need TE during the procedure to understand exactly which part of the valve we are at and where we are going to grasp the leaflet, confirm that this is the right spot, that you have decreased the mitral regurgitation, and if you think we are happy, you will release the clip and take it out. So it's a venous procedure. So before this device was approved, the trial that led to the approval was Everest 2, was a randomized clinical trial where there was randomization from 2 to 1. Control group was the surgical group, and the device group was a clip group, about 180 patients. And patients were followed for the 30 days, 6 months, 1 year, up to 5 years. And what did it show? That the clip was definitely effective and safer. Effective-wise, that it was not as effective as surgery. That's exactly what the conclusion was, that although percutaneous repair was less effective at reducing mitral regurgitation than conventional surgery, the procedure was associated with superior safety. So whenever you have a new device comes out, the biggest question for the physicians as well as the referring doctor is that, is this procedure safe? Yes, it was very safe. That's why it led to the FDA approval and approval of the patients with the degenerative mitral regurgitation. Just to show you a case, here was an 84-year-old male with history of hypertension, Alzheimer's disease, AFib on Coumadin, symptomatic severe mitral regurgitation, and multiple hospitalization due to heart failure. So primary MR due to ruptured chordae of the posterior leaflet with flail. So this is where you see this is echo-guided, and this is the LV, LA, lot of regurgitation, eccentric jet. So this is a TE assessment when we are doing the clip again. All this is a lot of mitral regurgitation into the left atrium. So you can see that, like I mentioned, the catheter, this is the septum. The catheter has gone through the septum from the right atrium to the left atrium, and it is right now in the left atrium. The goal is then you'll bring the clip through this catheter and try to get into the LV. So one clip is already placed with the MR, definitely with the reduction of the mitral regurgitation. And also what you have to do is, once you have placed your clip and you have reduced the mitral regurgitation, very important that you have now not caused stenosis. So if you see here, the max is 7, but the mean gradient of about 3. As long as your mean gradient has not gone above 7, and you know your mitral regurgitation for 4+ has gone down almost to 2+, you are okay, that you can think that you place the clip. If you are not happy with one clip, 2 or 3 clips can be placed. So this was our volume, 2017. We did about 51 cases here. For the other valves that are out there, this is clip for only regurgitation. What do you do if there is stenosis and you cannot do a BMV, or what is also called as MAC, which is mitral annular calcification resulting in stenosis? There are several. This is early clinical experience with several valves out there, and the valves that have been in the trial for the longest is the Abbott 10-dyne valve and Medtronic 12 valve. We were actually part of the mitral trial where they used Edwards Sapien valve, this valve we used yesterday, as a valve in patients with severe mitral annular calcification. And the trial was already presented during last TCT as well as in the AHA, saying that it is safe, that you can do it in a native, valve in ring, as well as valve in valve. And this is what we did yesterday, that you can place this Edwards Sapien valve in ring cases, showing that it is, the safe all-cause mortality is still high, because you see these are very sick patients, and the route that was used was either transapical or transatrial, and some of them were transseptal. So this was the first TMVR case we did here in Mount Sinai, 81-year-old female, several comorbidities, STS score of 9.4. has old valve. So if you see here, this is a old prosthetic valve with severe mitral stenosis and some regurgitation, both. This is a 3D echo. See that this is now not normal looking valve, stenosed valve. This is the procedure we did yesterday. You go through the inferior vena cava, transseptal, place the Sapien valve across, dilate it, and this is how it looks after the procedure. Very little mitral regurgitation and no gradient. Look at this valve. Nice, open. Just going quickly through the tricuspid valve. Is the tricuspid because 3 leaflets. So what is out there is the tricuspid clip. Actually, we are part of the Triluminate trial. And we have Dr. Gilbert Tang, who is the surgical director of the structural heart program. He's a PI. We have done a few cases of the tricuspid clip here, but this is what the study is, essentially that the prospective single-arm multicenter, it is a feasibility study, and the primary endpoint is for a patient with tricuspid regurgitation, that you decrease the tricuspid regurgitation, and right now we are looking only at 30-day outcome, similarly looking at cardiac mortality at 30-day outcome. Several other valves out there, but these are all in the primitive stages to try at the tricuspid level. So just to conclude, you have that the TAVR is approved for intermediate and high-risk patients, and TAVR for low risk is under the trial. Mitral clip results in clinically significant MR reduction in majority of the patients, is safer than surgery, mitral clip, with a shorter time to recovery, but is less effective than surgery for MR reduction. So clip is ideally suited for poor surgical candidates with appropriate anatomy. So it's FDA approved right now for degenerative etiology. TMVR, the device that we have for native disease, has potential, but we have a long way to go. All the other devices still in the trial. For the TMVR using SAPIEN valve for bioprosthetic degeneration has been approved by FDA, and we can do that. For tricuspid TAVR devices, early stages, very early stages, and promising. And for tricuspid clip, same thing, it is promising, but there are limited indications for this device. So just to see here, the patient coming out of percutaneous heart valve center saying that the alarm is beeping as he's going out of the hospital, saying, the security tag is still on your new heart valve. I need to know how many new valves do you have. So end is the same, get percutaneous valves and stay strong. Thank you.